creamy and come off. So that's how you expose the vessels. It's just the blunt side of the handle or something. You don't need to use a scalpel or scissors or anything like that. Just rub it with the blunt end of the instrument. So while a couple of you are doing that, the rest of you need to be over on cadaver and dissecting the posterior mediastinum, because there are several structures we're going to talk about that you're responsible for there. Okay? So I talked with a student this morning about who did not perform well on the practical, and I was told how many hours she studied on that practical, and it was about 6 hours or so, which is not even in the ballpark. So if you're not studying 12, 15, 18 hours in that lab, you're not going to pass. You're not going to do well. You need to be going, I would go home, study the material for a couple hours. I would come back up here at 9 o'clock at night and spend till 11 o'clock. I mean, these guys back here are shaking their heads. They can tell you that I'm not kidding. So this is, you're playing in the NFL now. If you're not studying 6 hours a night, you're not going to make it through this year. And next year, when you get to the clinical year, you're studying even harder. I was talking to Ms. Renner, who is a third-year student. She said the other day, she said, you know, I didn't think that would be possible to study harder than I did the first year until I got to the clinical year. So, you know, I would say at a very minimum 4 hours a night, more towards 6 a night to keep up. So if you're not doing that, you're not going to get through this year. Okay? So that was one of the issues identified with her. So anyway, here we go. Mediastinum and heart. You've seen this picture right here. This is the illustration that I gave you the other day, showing it through the angle of Louis. It's T4, T5, and I said that that's also the top of the heart. Well, that line through the angle of Louis also divides the mediastinum into a superior mediastinum and an inferior mediastinum. The inferior mediastinum is further subdivided, if you look on a lateral view, into an anterior, a middle, and a posterior mediastinum. So there's a posterior inferior, a middle inferior, and an anterior inferior mediastinum. The different pieces and parts that are in these different regions are listed out to the side here. This is, you'll pick up on this. It's not something you have to memorize because you're going to see it in the lab today and for the rest of the week. And it'll become intuitive for you anyway. Several of the things like the esophagus, the thoracic duct that I'll talk about today, the splanchnics, they're going to be in both superior and inferior because they run the entire length of the thorax, and that's going to become intuitive later on. If you look at a chest x-ray, a PA lateral chest x-ray, and it's called a PA because the direction of the x-rays going through the chest is from a posterior to anterior direction. The direction is this way. If you put the plate or the digital reader in the front because you want it closest to the area that you're most interested in, which is going to be the heart and lungs, you would shoot it at a PA. If you're interested in the spine, then you would shoot AP because you want the spine next to the reader. I'll explain why when we get to radiology. But anyway, there's a PA in the lateral view right here. You can see the anterior, middle, and posterior mediastinal regions in that view quite well. Now, just to let you know, on the anterior view, the PA view here, you see these little buttons. Those are not nipples, but they're the little electrode patches for to attach a monitor. So this is what you see right now. You took the chest wall off yesterday. What they have done here is they've opened up the pericardium, and I'll explain that later. But this is what you are going to be focusing on today. So when you refer to the large vessels coming in and out of the heart, they're called the great vessels. The most superficial view here is what you're looking at. If you clean off some of that fat there, you're going to find the superior vena cava. The two innominate veins, or brachiocephalic veins, join to form the superior vena cava. You've got a left and a right brachiocephalic vein. Another word for that is innominate vein. You'll see it on another slide. Remember, you only have one brachiocephalic artery, or trunk. You have two brachiocephalic veins that are created when the internal jugular joins the subclavian vein on each side. The inferior vena cava comes up through the diaphragm, and you can't see it when the heart is in place. Now, just to the left of the superior vena cava is the aorta, the ascending aorta, to be specific. And then beside that, behind it is going to be the trunk, the pulmonary trunk, that's going to give rise to the two pulmonary arteries. You can see the left pulmonary artery right there in blue. The two nerves that are easy to find in this region are the phrenic and the vagus. The phrenic nerve is going to be attached to the pericardial sac as it travels down to the diaphragm. I think most of you yesterday saw it. It's easy to find on both sides. Wow. The vagus nerves are also up here high in the mediastinum. The left one is easy to find because it goes right over top of the arch of the aorta. The right one is more difficult to find because it's buried behind all of this stuff here. But the left one is very easy to find. I pointed it out to most of you yesterday. You can see it's right there on the surface. Now, one thing that you're going to find in the superior mediastinum of young people will be the thymus gland. The thymus gland is a huge lymphoid structure. It sits right here behind the manubrium in a small child. As you age, it involutes, the lymphoid tissue involutes, and is replaced by fat. So yesterday when you pulled it, you saw that fat that was right here above the heart? That's the former thymus gland. By the time you're your age, like the adenoids, it's gone. It's replaced with fat. But in a child, a small child, it takes up a big chunk of the space in the superior mediastinum. In fact, you can look at it, you can see it on X-ray. Here's the normal superior mediastinum in an adult. That right there is the arch of the aorta. So that takes up a lot of the width. If you come over here and look at the superior mediastinum of this little kid, you see how wide it is? It's quite wide in comparison. But in adults, it's just fat. If we dig a little deeper, what we've done here is, this is the view I just showed you. There's the superior vena cava, the aorta, pulmonary trunk is right there. There's the phrenic, there's the vagus. If we remove the heart, so what we've done here is taken the heart out. There's the aorta right there. So the arch of the aorta would continue through there, right? So that section is through up here. You see that? When you take the heart out, when you remove this stuff, now you can see the pulmonary trunk and the right and left pulmonary arteries. Right in front of those will be the 4 pulmonary veins. the 4 pulmonary veins coming back from each lung. Who had the perfect cut yesterday? What group are you?
4.
4. Go look at group 4, their lung, it's a perfect cut. So they get double points, okay?
Thanks, Ronnie.
Now, here is the, so the phrenic nerve is gone in this illustration here, but it was attached to the pericardial sac. But you can see the vagi. There's the right one, there's the left one. Now, the left one, what it does is, as it descends past the aorta, it gives off that little trunk there. It's called the recurrent laryngeal. Remember we saw the recurrent laryngeal up in the neck behind the thyroid? Well, where does it recur? It recurs up under the arch of the aorta. Right behind this structure here, this ligamentous structure called the ligamentum arteriosum. It's very easy to find. And then it goes back up to innervate the larynx. On the right side, here's the recurrent, here's the vagus coming down. There's the subclavian artery. There's the recurrent on the right side. It recurs under the subclavian. So the right side recurs under the subclavian, left side recurs under the arch of the aorta. When we get to the embryology of these pipes in pediatrics or cardiology, I can't remember when I gave this lecture, you will see the reason why they're not symmetrical about where they occur. Right. Now the rest of the vagus, if you see right here, it splits into a bunch of hairs. It splits into a plexus. That plexus will form around the esophagus. Now, of course, the plexus gives rise to the cardiopulmonary ganglionated plexus to supply the heart and lungs that we talked about. But where it ends up here is around the esophagus. When you locate the esophagus today, it'll have a bunch of strings around it. Those strings are the vagus nerves. It forms a plexus, and it loses its characteristic right and left side. It's a plexus. It's a spider web around the esophagus. However, just before the esophagus dives in to through the diaphragm, the vagi coalesce into an anterior and a posterior vagal trunk. So you got a right and left vagal nerves in the neck, the plexus around the esophagus, and then an anterior and a posterior vagal trunk. The anterior vagal trunk is made up essentially of the left vagus. The posterior vagal trunk is made up of the right vagus. And just to give you a little heads up, the left vagal trunk is going to provide parasympathetics to the stomach, the liver, what's called the foregut, the proximal gut. The posterior vagus, or what was the right vagal trunk, is going to supply the mid and hind gut. So they distribute differently once they get into the abdomen. So if you look on that 9-page thing that I gave you originally on how the parasympathetics go, it's got the right and left vagus, and then I have what looks like that, and then an anterior and posterior vagal trunk. That's the esophagus right there. Okay, that's what that illustration represents. Okay, for those of you who are heavily affected with syphilis, Treponema pallidum is the name of the organism that causes syphilis. Back in the days, before the treatment, before penicillin, and it was untreated, advanced syphilis would produce, one, gummas. Remember gummas from the inflammation lecture? And two, it would invade the arch of the aorta. The bugs would get into the arch of the aorta, divide, form a mass in there. And because the left recurrent laryngeal nerve goes under the arch of the aorta, what it would do, it would damage the left recurrent laryngeal nerve. So that results in paralysis of the left vocal cords, and the prostitute would be hoarse because one side of the vocal cords is paralyzed. This is the ligamentum arteriosum. Well, since the advent of penicillin, you're not going to see this anymore. No one's going to let syphilis go that long. I say that, I don't know when the Tuskegee experiment was. I think it may have been after no, it was before the advent of penicillin. No, it was after the advent of penicillin because they didn't treat them.
It was during.
It was during.
It was during. It started and then they found it and then they didn't do it.
They didn't treat them, yeah. But anyway, now you're not going to see this type of situation, numbness or hoarseness due to this type of invasion. All right, so the ligamentum arteriosus, back when you were a little bitty embryo and you still had a placenta that was attached to your mama, you did not need your lungs to breathe. Your mom breathed for you, and the placenta is what exchanged the oxygen. So you don't need all that blood going to the lungs. So this used to be a duct called the ductus arteriosum, that when your heart contracted, the right ventricle would send that blood out the pulmonary trunk, and instead of going to the lungs, most of it would end up in the aorta. So it was it's called a right to left shunt. The right heart, being the right ventricle and the right atrium, is shunting blood to the left side, is going to distribute it to the rest of the body. Okay? So after you're born, after the cord is clamped, and within a few days after birth, this ductus arteriosum scleroses down to form a ligament. In a few people, it does not close, and it's called a PDA, a patent ductus arteriosum, PDA. You know, we'll talk more about the PDAs and this right-left, left-right shunts when we do cardiac lecture sometime this year. All right, so here's the deepening part. Here's our tighty-whitey carina. So we've removed all of the vasculature here. And so if I were to point to right there, and I would say, what level, where would you find this? You would say, right through the sternal angle, because that's where it bifurcates, right? So that's the superior mediastinum. From here up, from here down is the inferior mediastinum. On this illustration over here, it puts it all together. You should know this, because if you're ever trying to interpret a CT or talk intelligently to a thoracic surgeon, you need to know there's superior vena cava, there's the ascending, the arch, and the descending aorta, there's the pulmonary trunk, and then the respiratory system is in the back. But it's in front of the esophagus. If you think about it, there's your trachea in the front. The esophagus is behind it. All right, you see that little hole right there? That little hole is it's called the zygos. Let me tell you what that is. If we look at the chest wall from the lateral view here, take out the lung. Here's the hilum of the lung here. This is what we're going to see. Here are all of our intercostals right there. We got the sympathetic chain, the white and gray rami. The sympathetic chain is connecting all the ganglia. coming off medially, we see the greater splanchnics right there. You'll see it right here, thoracic splanchnics. The splanchnics, remember, are preganglionic sympathetics, and they're headed for the pre-aortic ganglia in the gut. The sympathetic. So the arteries, the intercostal arteries, come off of the aorta. You'll see that in a second. But the veins are different. Because you have the heart right here, you don't have a superior vena cava or an inferior vena cava. You don't have a pipe going behind the heart. You have the two cable systems emptying into the heart. So what drains the intercostals? Well, they drain into this structure called the Zygos system. And the Zygos vein, right there, drains into the superior vena cava. The Zygos vein on the right side drains into the superior vena cava. This is the right side of the chest wall right here. It's draining into the superior vena cava. So if I go back to the previous slide, right here, I've cut that. It's coming from the wall, draining into the superior vena cava that I've already removed. You can see this quite easily on a plain film X-ray, and certainly you can see it on CTs. The superior, the Zygos system. Now on the left side, it's different. On the left side, you have the top, we're going to make this simple. The top 6 intercostal spaces drain into a structure called the accessory hemiazygos. The bottom 6 drain into the hemiazygos. A comes before H. Accessory hemiazygos, hemiazygos. That's how you remember which one on top.
You said the top 6 is the accessory and the bottom
is the hemiazygos. So these intercostals drain into the hemiazygos. Bear with me for just a second, I'll show you how this works. Well, I'll show you right now how it works. Here's the azygos right here, draining into the superior vena cava. All of the structures on the right drain into the azygos vein. On the left, here's the hemiazygos. There's the accessory hemiazygos. Those two drain across the midline into the azygos. Whereas the intercostal and subcostal arteries just come off of the aorta, as you see here. The easiest way to do that, if you think about that azygos system, is if this is the that's the azygos. That's what it does. Okay, now there's a lot of variation on that, but if we just go with that theme, I'll be happy. Okay, and you'll see it in lab. You can find this vein easily in lab. It sits right on the bone, right on the vertebra. Now there's another thing in here we haven't touched on, even though we were doing the neck, but that's lymphatic drainage from the body. There's a duct called the Thoracic Duct. And it's illustrated in green here. It's between the descending aorta and the azygos vein. It's sitting right there on the bone. And it's thin-walled. It's like a vein. It starts down here in the abdomen in a structure called the Cisternachyli. Cisternachyli is this thing about the size of a quarter, where all the lymph drainage from your lower extremities and your abdomen and pelvis goes. All all the lymphatics from your lower extremity, your pelvis and your abdomen drain into that Cisternachyli. The lymph is pushed upward through the thoracic duct into the root of the neck, where it goes behind the vascular structures and empties into the junction of the internal jugular vein and subclavian vein on the left. It's on the left. The thoracic duct is only on the left. Now, in addition to draining the gut, the pelvis, and the lower extremities, it also drains the left upper extremity and the left thoracic wall. In other words, the entire left side of your body, essentially. There is a right thoracic duct, but it only drains the right side of the head and the right upper extremity, as illustrated by that black line right there. It too drains into the junction of the internal jugular vein and the subclavian vein, but it's so small you can't find it. You should be able to find the thoracic duct here in the chest, and if you go back up, if you still have your subclavian vein on the left and your internal jugular vein, you should be able to find where that thing enters, or the thoracic duct enters in there. I remember when I was a student, my first rotation was general surgery. I don't know if I told you guys this last year. It was with a little surgeon named Padma Raju. I'll never forget that little guy. We were in surgery. I was standing across from him doing surgery on somebody, or something in the neck. And he said, "What do you find in the left side of the neck that you don't find in the right?" I'm thinking, I don't know. It was a thoracic duct. What would happen if I clamped off the thoracic duct? I never thought about that. What would happen if you clamped off the thoracic duct? I would assume that you'd have lymphedema of the left side of your body. He said, nope, there are enough alternative channels that it would get shunted away. Okay, so I got that one wrong too. And he asked me about 6 questions in a row, and I didn't get a single one of them right. So I'm telling you, if somebody asks you, what do you find on the left side of the neck, you don't find in the right, it's the thoracic duct. Okay?
What happens when you clamp it off?
Nothing. That's what I just said. Did I just explain what happens when you clamp it off? You have enough collateralization so that the lymph will re-enter the venous circulation through other routes. Okay.
Got it.
Okay. You know, that's the second time we've like gone on to, 30 minutes later, she comes up with a question. That was the second time.
I came all the way from Hilton this morning.
Oh, okay. All right, you have an excuse. Hilton is next door to Lone Grove.
Yeah.
Lone Grove is the home of, what's the guy? Chuck Norris and 640 other successful people. Like somebody considers Chuck Norris successful. I don't know. There was a Chuck Norris museum in Lone Grove for years until they got pissed off at the people of Lone Grove and came up and got all of his stuff. You know that?
No.
Yeah. I mean, all of his stuff. He had like a pair of boots and a couple of other things there. Wasn't a whole lot. It was this decrepit little place downtown. So a friend of mine used to live in Lone Grove, and the way you would give directions to it, he's a PA now, who's a rotation site for us, so you better pay attention. So you would tell him to go, you turn at the Chuck Norris sign, and you go up into the high school. And the high school, the only place I've ever seen where they had prenatal classes offered at the high school. So you turn left at the prenatal classes at the high school, left on that road, goes right by the high school. You may know what I'm talking about. You go 2 streets over, and there'll be a donkey tied to a tree. I'm not kidding, that donkey was in somebody's front yard tied to a tree. You take a right where the donkey is, and his trailer is the first one on the left. That's how you get to Robert Lynch's house. You know Robert Lynch?
No.
No.
I know the donkey.
You know the donkey?
That's my great grandfather's donkey.
He works in the ER down in the Chick-fil-A hospital in Ada, which is a beautiful hospital. That's a rotation site for it. Okay. His dad was called Chicken. Everybody, do you know him?
No.
Oh, you said yeah.
Yeah.
Everybody called him Chicken. You know Chicken.
Yeah, I've heard of him.
Everybody down there knew Chicken. Chicken had a speech impediment. I could not understand a word that guy said, even though he was speaking English. But they called Robert the turkey growing up. So anyway, here we go. So what I'm showing you in this illustration here is the greater splanchnic nerve. Now, there are three splanchnic nerves, greater, lesser, and least. So the T5 segment here is where the first contribution to the greater splanchnic nerve arises. The greater splanchnic nerve is made up of contributions from T5 to T9. The lesser splanchnic nerve is T10 and 11, and the least splanchnic nerve is T12. You won't see any of these nerves right now, but you can see where T5, 6, 7, 8, and 9 are going to form the greater splanchnic nerve. If I put a tag around, that, you can say greater splanchnic nerve, that's fine. I know what you mean. Okay?
What?
If
You put a tag around what?
If I put a tag around that, if I put a tag around this, for example, it's really a contribution to the greater splanchnic nerve. But if you say greater splanchnic nerve, I know what you mean. Pericardium, let's go to the pericardium here. The pericardium has three different layers. And like the lungs, the heart grows, I say grows, they use that term loosely. It doesn't grow like the lungs, but it forms within this cavity. So you see the developing heart here. The heart is actually cool because it starts out as a single tube and then it folds on itself. And that's how you get the four chambers. It starts that process by folding. But it does all that folding inside of this cavity. Now the outermost layer of the cavity is called the fibrous pericardium. The fibrous pericardium is dull in appearance, and it is continuous up here. You see right here where they cut it up top? It becomes continuous with the outer covering of the great vessels. That outermost layer of the great vessels is called the adventitia. It becomes continuous with it. Because the heart is essentially just a vessel. It just happens to have folded. So structurally, it's the same as the aorta or the inferior vena cava. All right, now on the inside, another thing about the fibrous pericardium is there's no give to it. There's no stretch to it. It can't expand. Inside the pericardium, fibrous pericardium, is a closed sac like the pleura. You see there's a parietal layer which is inside the fibrous pericardium and attached to it. that's continuous with the serous layer, with the visceral layer that's the outermost covering of the heart. The set here is called the serous pericardium. So you've got serous pericardium and fibrous pericardium. The two layers of the serous pericardium are visceral and parietal. So you have a parietal layer of the serous pericardium. So from outside in, if you were to take a bullet, it's going to penetrate the fibrous pericardium, then the parietal layer of the serous pericardium, and in the pericardial cavity, and in the serous layer of the visceral layer of the serous pericardium. That would be the route of the bullet. While the fibrous pericardium is dull in appearance, when you remove the heart and you're looking at this underside here, that underside is, you're looking at the underside of the parietal layer of the serous pericardium. It's shiny. That's that, if you're just looking at, if all you have is this flap right here, and you're trying to determine which surface you're looking at, the fibrous is dull, the parietal layer of the serous pericardium is shiny. Now, when your heart started folding and dividing, you had all of these tubes. You started out with a tube on each end, and what you wound up with was a total of about 7 tubes going in and out of this folded heart. If you look at these tubes, which are the great vessels, they're arranged in a backward 7 appearance here. Their location is a backward 7. Like that. The reflection of the parietal serous pericardium onto visceral pericardium is where you see this 7. You see you're cutting through the two sides of it, where it reflects onto there. You follow me?
No.
Okay, it's going to be easier when you get in the lab and you actually put your fingers on it. But if you're going to reflect the parietal layer onto the serous layer, the parietal layer onto the visceral layer of the serous pericardium, that place right there, if I cut this heart out, you see I'm going to have 2 layers. I have 2 layers right there. 2 layers right there. 2 layers right there. 2 layers right there. It's just a reflection of the parietal onto the serous, visceral layer of the serous pericardium. That's all it is. And it's in the shape of the backward 7. Now, if I were to put the heart in place here, understand that if I took my right hand and passed behind the heart over here, if I took my hand and passed it behind here into this oblique pericardial sinus, I cannot push my hand all the way over to this side, and I cannot push my hand up because of these reflections. You see, it's a blind pouch because the reflections are coming up here, and I can't pass it up, and I can't pass it over. All right? Similarly, if I take my left finger, index finger, and I pass it above the reflection, up here, behind the aorta, superior vena cava, that's the transverse pericardial sinus. My fingers will never touch. And it just has to do with the reflections of parietal with visceral layers of the serous pericardium. Now, the reason I'm telling you this is because this is really important if you're doing cardiothoracic surgery and being able to get to and work on vessels and valves. You have to know what you're cutting through. before you take your heart out today, reach around behind it, put your finger across the top, and you can just easily see what I'm talking about. All right. Because the fibrous pericardium does not expand, any leakage of fluid into the pericardial cavity is not good. Ordinarily, there's just a couple of cc's of fluid in there to decrease friction. But in the case of blunt force trauma to the chest, again, falling off the roof, hitting the steering wheel, where you rupture your coronary arteries or coronary veins, you're going to be bleeding into that pericardial cavity, and it's eventually going to fill up with blood. Same thing also happens with metastasis. Metastasis, if it gets inside the pleural cavity, secretes a lot of fluid. Metastatic cells do in general. That fluid's going to collect in the pericardial cavity. So get this, every time the heart contracts in systole, more fluid enters the space. And then it tries to relax, and it can't relax all the way because there's fluid there. And with every contraction, more fluid enters the space. And eventually, the heart has nowhere to relax to. So what you have is normal activity in the heart. This is the EKG right here, but there's no cardiac output because there's no end-diastolic filling to generate a cardiac output. This is another case, cardiac tamponade is what it's called. This is another case or a reason for PEA, pulseless electrical activity. On ultrasound, fluids show up as black. Here's the heart right there with two of the chambers. You can see all this fluid in the pericardial cavity here. On this CT, you can see the heart, and definitely the pericardium is filled with fluid. And up here, you see how wide the heart is? It's wide because the whole thing is filled with fluid. Also, because when you do an EKG, you're putting electrodes on the surface of the chest. You're recording heart activity through the chest. If you put a bunch of water between what's creating the electricity and your recording device, what you wind up with is consistently low voltage QRSs. So characteristic features of tamponade, low voltage QRS on EKG, widened cardiac shadow, muffled heart sounds when you listen in there. If you're not at full tamponade yet, because you're putting your stethoscope listening through water, their heart sounds are muffled, they're distant. Falling blood pressure, PEA, all of these things are characteristic of cardiac tamponade. To fix it, it's very simple. All you do is you take a needle on a big syringe and you pass it through the diaphragm into the pericardial cavity as you're pulling back on the plunger. When you relieve the fluid, you should get a return of blood pressure. A friend of mine used to work at the OU ER, and he said anytime he had a patient that came in PEA, if they died, right there at the end, he always stuck a syringe in the pericardium, and he stuck 2 darts in the chest and left them. Because he didn't want them coming back from the medical examiner's office saying, well, the reason they died, the reason you didn't save them is because of tamponade or tension pneumo. So everybody in PEA, one of the things about PEA you'll learn is there are treatable causes. This is a treatable cause. Tension pneumo is a treatable cause. Okay?
So even after they died, he put it there just like cover himself? Like
basically to cover himself.
Yeah.
But, if it was a tension pneumo, I mean, that would fix the problem. A lot of times you just don't ever know. There are treatable and non-treatable causes for PEA. for example, tension pneumo and cardiac tamponade are usually the result of trauma. So that would be one of the first things he'd do if that was the case. But there are also, I said, untreatable causes, like a myocardial infarction is an untreatable cause. There would be no indication of putting darting the chest or tamponade if there were in the absence of trauma. Yet, if there was PEA, he would still do it, but not expecting a resolution. Okay. Layers of the heart. The 3 layers of the heart. The outermost covering of the heart is the visceral layer of the serous pericardium, also called the epicardium. The heart muscle itself is the myocardium. And in the inside lining of the heart is the endocardium, which is continuous with the endothelium of vessels. If you look at the heart borders, in situ essentially means in place. So if you put the heart in place and you're looking at the borders here, what forms the right heart border is the right atrium. What forms the left heart border is the left ventricle. Not the right ventricle, it's the left ventricle. There are 2 grooves on the heart, really 3. There's an anterior interventricular groove and a posterior interventricular groove that's between the 2 ventricles. So this is this demarcates the right ventricle, and that's the left ventricle that you see right there. Most of the left ventricle is on the posterior side. And then there's a groove that separates the ventricles from the atria. That's called the coronary groove. When you're referring to the heart, the lateral border of the heart is also the apex of the heart. The point of the heart is the apex. The base of the heart is down here where the great vessels enter and leave. Why don't we take a little bit of a break and then we'll